We are going to do the virtual implant planning today. So before doing the planning, we will see the 3D reformatted image view. Already we placed implants, 6 implants. We will see the 3D reformatted image. The patient has 2 single piece implants on the right side. Patient is a heavy chewer, so that is why we are planning for pterygoid also. Otherwise, we can treat this patient by all-on-4 also. You will see the panoramic image. So this is the panorama. 3 single piece implants already placed, one in the incisor and another 2 in the premolar molar region. So observe the sinus wall and the sinus floor and the anterior sinus wall. If you see here the left side sinus wall is uniform like a slope type, but here it is 2 separate expansions are there. It is called a double balloon. This is the nasal floor, nasal spine. So this is the buttress area. The buttress area is quite wide for this patient, which is a good thing. This is the tuberosity with the pterygoid area. Okay, so first we will plan for the pterygoids. Right pterygoid will plan. So this is the right pterygoid cross section. So we will see the little bit of anatomy. Sinus. This is the sinus floor. This is the distal sinus wall. The sinus is clear. This is the tuberosity, very porous bone. So this is the junction. This is the hamular notch. This is the okay. So our plan is to start from the 7 region and to this is our target area. So starting point and ending point, target area. So in the mesodistal plane, this is our angle, and in the buccopalatal angle, this is our angle. So this is the tuberosity crest. From the mid crest we can start. If we go straight, we will enter the lateral pterygoid plate or into this space, which is not recommended. So we are tilting palatally or medially, about 10 to 15 degree angle. So if you see here the bone density is good, quite reasonable, but here it is around, we can see the HU measurement here, it is in, so the tuberosity is very porous, but as we go near the pterygoid junction, it is quite good. So we are planning for a conventional implant, JD implant. So tentative length is around 3.75 into 8 in most of the time. Okay, even we can place a longer implant, even 20 or 22 also we can place. So we will see the 360 degree overview. It is good. We will see the anatomy of left pterygoid. So this is the left pterygoid, sinus floor, distal sinus wall. So this is the key factor to check. What is the distance between the sinus wall and the pterygoid junction? If the distance is very good, then it is easy case. The more the sinus expands here, the more difficult. And also the sinus floor. The more sinus floor is towards the tuberosity, the more challenging case becomes. So this is a easy situation. Based on the classification, it is PRP 1 type. Okay. So from the second molar we are starting. The ending point is in this radioopaque zone or the junction zone or the pillar zone. So in the buccopalatal angle, this is the correct angle. If you go straight, we will go into the dangerous spaces, infratemporal space, or into the lateral pterygoid plate, which is not desirable. So this is the lateral pterygoid plate. This is the medial pterygoid plate. This is the pterygoid fossa. Excuse me. So you can see the tuberosity is fully porous bone. Only here it is cortical bone. So tilt medially and target medial direction. We will see the 360 degree angle. Sorry. Now we will see the right nasomaxillary buttress implant or right distal tilted implant. We will remove this single piece implant. Then we will treat this area as an extraction socket. That's it. So this is the double expansion. This is one expansion. This is one expansion. So starting point is this from this socket, implant socket, tilted medially. So starting point we have defined. What is the ending point? How to decide that? So there are basically only three options in the ending target area. One is in the nasal corner. It is called the NC point, and another is in the nasal floor, and another in this area, the nasomaxillary buttress area, lateral to the lateral nasal wall. So our target is in it is just above the nasal corner. So the sinus expansion is favorable for this patient. So we have freedom here to engage anywhere. We can engage the implant here, or even in the so-called nasal corner point. Okay, a lot of bone is there. It is a straightforward situation. Now we will see the left nasomaxillary buttress area. So left side patient is having a canine. So from the canine, this is canine, this is first premolar, this is second premolar. From the second premolar we can start. We have to tilt medially. So how much to tilt medially? We should not go into the sinus. So for that we are using this trick. You just bring the implant out and check in the reformated image. So it is coming out here, just lateral to the nasal corner. So after flap elevation you can mark with pencil here and you can target that point. So from the second premolar we are targeting towards the nasomaxillary buttress area. Now we are coming to the axial implant. Axial implants, two implants. The plan is very simple. Just expose the nasopalatal canal. Just next to the nasopalatal canal, you have to place two implants. If you see here already there is one single piece implant close to the nasopalatal canal. There is a lesion in the lateral incisor. First we will see the right axial implant. Most of the time we place the implant between central and lateral. This is the periapical cyst, is there, small lesion. The nasal cortex is good. This is the mesiodistal view. This is the buccopalatal view. The ridge anatomy is favorable. Just drill along the palatal wall, that's it. Maybe around 18 mm implant also we can place. 3.75 is better. Left side axial implant we will see. Here the anatomy is little challenging. We'll see. Because of the implant and the yes. So between the implant and the lateral incisor we are drilling. Similar anatomy to the right side. If we see here, there is a small concavity here, that is a labial concavity which is present in naturally. For some patient the labial concavity will be much more severe, but for this patient this is very less, which is favorable. That's it. So this is the planning for the upper jaw. First we will finish the pterygoid, then we will finish the upper four. Even this patient we can do all on four, but the patient is heavily built with heavy chewing forces we are expecting. So to prevent prosthetic related issues, we are going for pterygoids also.